So thank you for the introduction. Today I'm going to be talking about how is the COVID pandemic affecting our hard to reach populations. So I was having a think about what hard to reach means, and I think it means lots of different things for our HIV population. And I'm going to start with the most obvious, which is our homeless PWID population. So since 2017 in Glasgow, we've had a HIV outbreak amongst our homeless PWIDs. And to date, I think we have 127 of these patients who have been diagnosed HIV positive. 77 of these patients are on community pharmacy dispensing to mirror their ORT. So they go into pharmacies all over Glasgow, and this is can be a lot of work to set up, and this patient group can move about a lot, but they get their antiretroviral therapy daily supervised along with their ORT. The remainder of these patients are supplied via outreach clinics or nurse delivery, so a couple of different models, and very few of these engage in hospital outpatient appointments. So prior to COVID, this was a complex group of patients, but we'd known about the problem since 2017. We'd mobilised staff and we had a really effective MDT. However, of course, COVID changed so much, and it was really important that we remained, that we focused on engaging these patients as much as possible. So I guess what did we do and how things changed? So prior to COVID, as I said, the dispensing of the antiretrovirals was done supervised in community pharmacies along with methadone or other ORT. During COVID and in our kind of peaks of lockdown, antiretrovirals were all switched to weekly dispensing. So I guess straight away there's concern there with compliance. Prior to that, we had a service where the community pharmacies would link in with our team if patients stopped attending, and we would know if there was issues, we would track them down. That switched to weekly. And after COVID now, we are getting back to normal, but we're on for most patients 3 times a week dispensing. So the living arrangements of these patients, they were homeless and spread over large areas of central Glasgow. There's a lot of work for the staff to find and engage and keep in regular pharmacies. So that was no mean feat, and often involved a lot of work to make sure doses weren't missed. During COVID, hotels were used, which was great. There was a known address, and these patients were much easier to engage. So for all the huge difficulties that COVID brought, that was certainly one positive. But now we're in a situation with the hotels closing and the patients are beginning to scatter again. And again, just going back to very labour intensive work and finding and setting up new pharmacies. And testing, a big issue with testing was that it was previously carried out in outreach centres by our nurses, our outreach nurses, or in our addictions clinics. And all our testing in addictions clinics and a variety of other settings halted pretty much completely during COVID. And although I use the word after cautiously, but although we're kind of hopefully coming out of the worst of things, they're still quite slow to progress with restarting testing. So what about our hard to reach patients with our hospital outpatients? So we switched from face-to-face to telephone consultations, and these were preferred to video in our patient group. In the early lockdown, most appointments were pushed for 3 to 6 months anyway, and supply was given for our stable patients, certainly. Was supply only without the need for an appointment in the first instance. Following that, nurse clinics for bloods were set up, and then we moved into a system where there was a medical phone consultation 2 weeks later after the blood results had been reviewed and the prescriptions were collected from pharmacy. Although in the early days there was a lot of posting out, particularly shielding patients or people isolating, but we utilised that a lot. But the pharmacy kept very busy. And also we were very lucky to have good support from the Terence Higgins Trust and other third sector organisations for supply and support to patients. I work in a teenage clinic, so this is based in the paediatric hospital, and these can be a difficult group to reach of patients as well, and again different issues that we had to deal with during the COVID pandemic. So it was really important not just to focus on the supply of their medicine and to engage in them. We really needed to understand everything else that was going wrong for them as well. And for quite a few of our patients, that was quite a lot. So lots of issues with homeschool. We had some patients who had only, been in the country for less than a year and were still trying to just understand how to live in the UK. Problems with homeschool, like access to computers, family support for issues, and lots of financial issues with this patient group. So, actually what worked well with our team was, again, linking in with other organisations. We managed to get funding for computers for patients struggling with the homeschool, and a lot of differences that could be made, but a lot of problems for our 13 to 19-year-olds during COVID. So we posted more prescriptions again, because our paediatric clinic covers a much larger geographical area than our adult clinic, which is board specific. And regular engagement with our pharmacists and our nursing staff to maintain what is quite complex regimens for these patients. So some of our teenagers, of course, are all vertical transmissions, have been through lots of different and tried and failed in lots of different regimens, and some of them don't have many options left. So it was really important that we remained engaged with them, and if we couldn't see them face to face, that we did link in and do everything that we could to make sure that these regimens were protected. Some other hard to reach patients that we had to deal with were literally hard to reach, our travelling patients. So in the first instance, patients from abroad or other parts of the UK who were trapped in Glasgow. So small supplies were given free of charge in the first instance, and we can access, we can give the vast majority of patients antiretrovirals outside our clinic area for no charge, which I think is perhaps easier where we are than in other parts of the country. And longer supplies were of course supplied as well, but we tried to link in with blood monitoring and contacting other clinicians and clinics around the world where possible, and that was a big role for the nurses and pharmacists there. And similarly, on the other end of the spectrum, we had patients who were trapped around the world, so a lot of anxiety caused there. Help was required to access medication, so we quite often contacted different clinics around the world and sent information if it was required. And then there was some national, a national protocol was written by the HIV pharmacy group in Scotland. So again, we found that different HIV pharmacists around Scotland were having the same problem, and we thought it best to kind of put a protocol together with regards to handling these patients. New HIV diagnosis during the pandemic, we kind of followed the BIVA recommendations to if blood monitoring was going to be a problem, and went for Biktarvy, which of course has a high barrier to resistance. It has a good option. It's a good option in the absence of blood, so renal, HBV, if there's no HLA B5701 monitoring, then it's a good option. Currently, we're in a better situation. We do have blood monitoring re-established, and we are in a position where we can go back to choosing any antiretrovirals. Similarly, with switches during the pandemic, in the first instance, we didn't do that unless it was, of course, urgent. So there was a pause on switches from abacavir for patients with high Q risk, for example. Reviews of medicine switches to single tablet regimens for simplicity. switches to review for any future drug interactions. So of course, if there was any pressing drug interactions, that switch was made, and things like reviews for cost saving, these things were all put on pause, and we just kept maintaining our patients on what they were on if that suited them. And now, thankfully, we're in a better position where we can start our medication reviews again. Our pharmacist clinics are full, which again saves medical time, because we're moving into a busy area again in Christmas. We've got a lot of staff shortages, and staff are being moved to different areas, and we can return to individualised therapy and looking at treatment planning. So at the start of the lockdown, one of our registrars did a kind of patient and staff survey just to have a look at what the issues were. Was there any red flags that we could look at that we could try and fix with regards to access, so remote consultations, phone. So we just smallish numbers, 38 patients and 34 staff members. The majority had been living with HIV for some time, 45 to 54. 92% English is the main language, but identified a whole host of issues that we knew were there, but it was important to kind of get this data, and I think it would be important to follow on from the studies. I think on the most part, it was fed back that the patients did feel they could discuss some important issues during remote consultations, but it's still important to look at the percentages that didn't, and this was just some of the comments and the feedback. So it was seen as an opportunity to modernise the service. Patients felt like it kept them safe. Some of the negative aspects, perhaps, that patients missed the social aspects of attending clinic. There was concern about less monitoring of their condition. There was concern about language barriers and inability to perform physical examinations, and some patient feedback like struggling to take in a lot of information over the phone. So overall, 68% of patients and 82% of our staff that were looked at felt that the future should be delivered during a combination of face-to-face and remote consultations. And I think that's really important now that we are moving forward. We're in a position where we can, and the most part, go back to face-to-face consultations, and maybe not right now as we move into winter, but certainly, hopefully, once we get over this hump, we will move back as much as possible to face-to-face. But I think certainly there's a group of patients we've recognised where this actually works better for them, and it would be good to have that hybrid model. So for our difficult to reach patients, what do we think that we did was a success? Well, we maintained our outreach nurses and pharmacists where possible for our homeless patients, and that there was issues here, of course, but there was a lot of time-heavy linkage with community pharmacies and making sure that supplies were maintained, and that was something that I think the team did really well. All supplies were maintained, and again, a lot of work there, so via hospital pharmacy, home delivery, outreach nurse delivery, or homeless outreach centres, and this was very much an MDT approach. Clinics were repurposed to allow for easier access. So in our infectious disease clinic, for example, we had a kind of complex post-travel clinic, and with nobody travelling, that freed up some space. So just, moving into the travel clinic to minimise numbers in some of our other clinics. And then opening of phlebotomy hubs around the city, so patients didn't have to travel so far. And I guess, like anything else, what were some of our learning points, just to finish off? So one of the first thoughts was that, it would be a nice thing to move lots of patients to home delivery, but actually, these companies struggled as did many others, and there was issues with a lot of staff issues and absences, and sometimes that was delayed. So we realised that our own service and continuing with outpatients was a good option as well. And where possible, we maintained a kind of 3 to 4 month supply. there was some concern raised that if we moved every patient to 6 months or beyond supplies, then it would cause supply problems that not unlike we're seeing with the petrol at the moment, and of course shoulders were the exception. But if we kind of kept to the same, generally the same supply amounts, then it would minimise problems of supply. And I think just to identify and learn that patient anxiety was really high, and we learned that, you know, phone lines became really, really busy, and it was important to move staff and put some time to that, and that affected pharmacy and nurse time as well. So, I mean, overall, I think the service is better, and as we come out of things will be lots of things that we've learned, but it's certainly been a journey. But I think with regards to our supply, with regards to our control of our HIV, particularly with our homeless PWIDs, we haven't seen huge problems with drop-offs and viral loads, even with all the changes. And I think that's testament to the strength of the team and all the hard work that's been put in by the full MDT. So thank you very much. I'm happy to discuss anything further.